So let's talk about adolescence and how we think about mental health and how it integrates with sexual and reproductive health care and HIV care. So I like to make sure that we're framing adolescence as a time, as a time of critical development and a lot of good things happening. So one of the problems that that the medical establishment makes when it comes to adolescence is that we are overly negative. We talk a lot about risk, we talk a lot about bad things, and we don't talk enough about the fact that adolescence is a fantastic time of life, right? So for those of you who are over the age of 25, do you remember what it was like when you loved someone under the age of 25? Do you remember what that was like? It was better then, right? Yes? We're more passionate, we have more energy, we're more interested in justice, right? These are key elements of adolescence. And so we first want to frame adolescence as a positive, important period of life that we need to go through all of the ups and downs in order to become high-quality adults, okay? So this critical period of adolescence results in a lot of changes. And those changes can increase your likelihood of being exposed to certain health challenges. So we see an increase in mental health conditions, sexually transmitted infections, and transmission of HIV starting in adolescence and often peaking in young adulthood. And so you need to understand how adolescence works together in order to create a kind of the perfect storm for some of the things that we worry about and why we have to address it holistically. So in the past few years, I'm sure many of you have experienced this firsthand, which is that we've had a lot of an increase in mental disorders over the past decade or so. People talk a lot about the mental health crisis occurring due to COVID. But prior to COVID, we actually already had an increase in adolescent mental disorders over the past 20 years or so. COVID absolutely did exacerbate that trend, but the trend has been ongoing. And there's a lot of ideas about potentially why that might be. About 4 to 8 out of 10, depending on where you are, adolescents who need mental health treatment receive it. So if you're in a place where there isn't adolescent-focused mental health care, you're going to be closer to 4 out of 10. And if you're in a place that has a high volume of adolescent specialty mental health care, you're going to be closer to 8 out of 10. Now, the key to that is that you have to be seen and understood as having a mental disorder. And so some people estimate that the gap is much larger because a lot of young people don't ever get seen. 1 in 6 people worldwide are adolescents, right? So we should be really thinking about adolescent mental health as a global priority. And up to 20% of these youth are going to have mental disorders at some point, and about 50% are going to say, under the age of 25, at some point, I had enough symptoms to be considered somebody who has a mental disorder, okay? So what about the brain development makes this more likely in adolescence? So who knows about adolescent brain development? Raise your hand if you know about adolescent brain development. I'm sure there's a lot of smart people in here. Okay, tell me what you know about adolescent brain development. Go ahead. Yeah.
I know different parts of our brain develop at different times. We have this particular part of our brain frontier, that's the
frontal lobe, yep.
Which is responsible for our cognitive function, for higher executive function, being able to make decisions, being able to reason. Nobody can hear me?
Yes, being able to reason.
Yes, being able to reason, and this only fully develops just at the end or towards the end of adolescence.
Which is when? End of adolescence? Who's got a number? 20, go ahead. 25? Anybody else? You're cheating. You're not supposed to answer. She's my mentee. So 25 is when your brain stops developing. So what's happening here, a lot of times when people think about adolescent brain development, which is a crucial time of life, right? The only other time of life when your brain develops as much as it develops during adolescence is between 0 and 2 years old. So it's exciting, okay? We should be excited about adolescent brain development. When we talk about prefrontal cortex, we often talk about cognitive ability. But what that's saying is adolescents are dumb, right? If we say that their prefrontal cortexes are not complete, have not completed their development, and therefore there's a cognitive issue, then we're saying that they're not that smart, right? That is not true, right? We know that. So cognitive abilities is actually not the issue. So remember how I was talking about falling in love as an adolescent, right? So falling in love as an adolescent illustrates some of the combination of things that happen during brain development that makes risky behaviors more likely, okay? So you're going to have your prefrontal cortex development in green, so it's going to be developing all along adolescence. And then you're going to have limbic system, which is the emotional side. So you notice the limbic system goes up and then down. So that's why we love more passionately as adolescents, right? Because our emotional centers are peaking during adolescence, and then we get a little bored with the passion, right? So then the next part is the reward pathway. So you see the highest part on here is the reward pathway. So the reward pathway of an adolescent and a young adult are going to be much more exciting than it is for somebody whose brain has stopped developing. Okay? Life is greater as an adolescent and young adult. Okay? I kind of sometimes want to go back there and have that much fun. Okay? So it's an important part of life because otherwise, what are we going to do? We're going to be hanging on our mom's leg until we're 25 years old. Right? So we need to be able to step outside of the home, step outside of the nest, make some friends, make some mistakes, so that we can be fully functional adults. So what that also means is that some of the behaviors that are going to lead to exposure are also going to be starting in adolescence, right? So one of the things I like to talk about is when parents say, my teen just lies all the time. I say, well, fully formed adults lie about 4 times a day. So what we're talking about is the start of autonomy, access to risks, etc., that starts in this stage of life. Couple that with more excitement, more passion, and you get some increased vulnerability. Okay? So in addition to the brain factors that are going to make people vulnerable, we also have the social determinants. So we have mental health problems as being influenced by the social determinants like food insecurity, access to healthcare, housing instability, racism, oppression, stigma, poverty, and economic instability. So we see how these things are going to hit all people, right? The social determinants affect all people's health, but it's going to affect adolescents particularly because this is, again, the time of launching out. So if you have poverty and economic instability at a time when you're trying to develop your sense of self, it's going to hit you a lot harder. Whereas when you're a younger person, you can sort of just play your way through some of the things that might be making you nervous. Food insecurity is going to hit you at a time when your body needs extra energy to go through puberty. So, and that brain development. So you need a lot of energy for all those brain changes, okay? So housing instability, stigma, access to healthcare, those are all going to be negatively affected as well because this is when adolescents are going out on their own, right? You go to the doctor for the first time on your own, often during adolescence. And so some of the barriers to healthcare access are going to hit adolescents harder because they also kind of don't know what to expect. So there's an additional component. So we've noticed that there's all the brain changes that happen during adolescence normally, right? So if you are perinatally infected with HIV, there's another component of potential neurocognitive effects, right? So we have researchers like Prof. Matsaba with his colleagues, Dr. Lowenthal and others, who've actually looked at this in our population. And we know that there are some neurocognitive effects that occur for people who've been living with HIV for their whole lives. And some of the things that might be affected are attention and processing speed, your ability to, that means that your ability to sustain attention or multitask, things like that, that might appear like attention deficit or other things like that. There are going to be other things that add to that. So if you've had any inflammation just from illnesses, but also due to the infection, we talked about the normal adolescent process of brain development, and then you have the double stress of not only being a young person that is going through the normal hardships of being a young person, but now you also have the stress of chronic disease. And the stress of chronic disease is not unique to HIV, but it's definitely something that causes a lot of emotional and mental distress. The other thing is that when we look at adolescents holistically, right, as whole people, we think about what does it take for a young person to be a thriving adult. So number 1, 2, and 3 is educational attainment. So if you don't do well educationally, it really takes you on a totally different trajectory. So having opportunities for different types of educational attainment, so not just the traditional schooling, uni pathway, but other ways in which if you're cognitively struggling due to potential neurocognitive effects, then that's also going to affect your mental health and your hopefulness and your ability to push through some of the hardships that are inherently associated with having HIV or any chronic disease, truthfully. So then we talk about treatment adherence. So if there are times in which if you are having neurocognitive dysfunctions and it's difficult for you to hold on to a lot of different types of information, then you might have decreased compliance to your medication. And there might be increased risk behaviors like substance use and unsafe sexual practices that could be associated with cognitive disorders. Now, the important thing to note here is that there's a spectrum, right? Some people have no neurocognitive effects. Some people have high levels of neurocognitive effects. Some people have it only in 1 or 2 domains. And one of our commitments needs to be to providing the support people need to still have school success and still have educational attainment, even if they have neurocognitive effects. One of many soapboxes, okay? So there's a bidirectional relationship between mental health and sexual decision-making. And so mental health and sexual decision-making is a direct bidirectional relationship. Okay, so the things that are going to trigger mental illness, like depression, anxiety, some of the sub-disorders that associated with that, the effects of trauma on the brain, are going to affect your risk behaviors. So if you're depressed, you're more likely to use substances. You're more likely to treat yourself with substances. If you are the same things that are going to trigger your poor mental health, like food insecurity or poverty, might result in you being more likely to partake in transactional sex or unprotected sex or having multiple partners to get resources or just out of loneliness, poor self-esteem, things like that. So they're all intersecting in creating a higher likelihood of co-occurrence of these various issues during adolescence. So when we talk about trauma as one of those triggers, one of the things that we talk about a lot in pediatrics is this adverse childhood experiences. So these are potentially traumatic events occurring before the age of 17 that can have a lasting negative effect. The WHO definition is some of the most intensive and frequently occurring sources of stress that children may suffer early in life. So these are things like witnessing domestic violence. Actually, on the list is experiencing a divorce, particularly a contentious one, if you've had the death of a family member that was close to you as a caregiver. So as you can think about it, some of these things we know are more likely in the populations that we're talking about here. Our kids that are more likely to get multiple sexually transmitted infections, our youth that are more likely, that are living with HIV, they're more likely to experience these ACEs because of the nature of the ecosystem that they're living in. So when you've experienced trauma, it actually interrupts your brain development. So those areas that are associated with impulse control and risk assessment that are developing, that prefrontal cortex that's developing during adolescence, can actually be can also be halted or altered by experiences of trauma. Okay, so trauma can very much negatively affect the way our brains are developing without any baseline neurocognitive issues or anything like that. So if you're putting trauma on top of the normal changes of the adolescent brain, then it can really have a significant negative effect and lead to significant mental health challenges. And then obviously, if you witness the death of a caregiver or whatever, it can be hard for you to emotionally regulate. You might get anxiety, depression, post-traumatic stress, things like that, just by virtue of thinking about the loss of a parent or thinking about the breaking up of your parents and stuff like that. So the other element of mental health is substance use. So I think about substance use as a part of mental health within the same umbrella, but we often think about it kind of separately because there's a component of willfulness in substance use. If you become addicted to substances, then that is a mental illness, and it's something that we have to think about as treating within the list of mental disorders or mental illnesses that we might be treating. But substance use in and of itself is its own issue. So even if I'm not addicted, even if I don't have a substance use problem, there is going to be an effect from substance use. So again, adolescence is a time of experimentation, right? So we're out there in the universe trying to figure out life, right? But when some of the things that you're experimenting with are substances, it can also lead to some of the downstream effects that we are not fans of, right? So the substance use is going to create a bridge between the mental health issues and the STI risks, as we saw in that previous figure. And it becomes a cycle of reinforcement. And we know that untreated mental health conditions are going to result in coping mechanisms. So from an impaired decision-making standpoint, substance use is going to affect that same prefrontal cortex that we've been talking about, which is also going to reduce the impulse control. So you're starting out with an impulse control that is not as developed as we would potentially like, but it's a part of the process. And so then you add on substances, which decrease your impulse control further, and then your ability to assess, is this a risky situation or is it not, is going to be reduced by the substances. So it's like putting a little brain damage on the brain development, right? And so you're going to do more increased sexual encounters. And then from a coping standpoint, if you have depression and you don't have treatment for that depression, motokwani, daga, marijuana, whatever you want to call it, is going to work for you, okay? It's going to make you feel better. It's going to help you sleep. It's going to help your appetite, right? So you're going to, like, oh, well, I feel great when I'm smoking, right? And so a lot of young people are using drugs to also self-medicate for the various mental illnesses that they're going through. And we've heard a lot about stigma and discrimination. The one thing I will tell you is that we have studied this in Botswana, and despite Botswana coming a long way and having youth-friendly services and having youth-specific care, we are still seeing lots and lots and lots of references to stigmatized care. And I think our colleagues from Bonella was talking earlier about the defilement issue. This really does stop people from getting health care, okay? So that's my other soapbox. We really need to figure out the issue of defilement. Okay, so stigma and discrimination from healthcare workers, self-stigma, anticipated stigma, it actually stops young people from getting care. So the answer is holistic adolescent care. That's my thing. I'm an adolescent doctor. You walk into my office. I tell you I take care of teens. I don't tell you I take care of HIV. I don't tell you I take care of your lungs. I tell you I take care of teens. So I think about you as a whole person, okay? So I know all these things about you. I know that trauma might be affecting you, substance use. So I'm going to screen everyone, okay? If you come into my clinic, everybody's getting screened for depression and anxiety, okay? And even if I'm not thinking about mental health, I'm just thinking about sexually transmitted infections and HIV, I'm always going to approach the situation from a trauma-informed perspective. So in brief, what that means to me is I don't need people to disclose all of their business, okay? So if a young person comes in and you're pretty sure they're sexually active, but they don't want to tell you for whatever reason, you don't have to push, but you can offer the services. Hey, some teens say that they have symptoms. Is this something that you might be interested in getting treatment for? So trauma-informed means somebody may not want to tell me the whole thing, but I'm still going to offer them everything as if they did. Okay? So we know that integrated care, when you put it all in one place, right? The HIV care, the STI care, the HIV testing, the mental health, that there are tons of benefits. A 40% increase in mental health screening, 35% improvement in STI testing, 50% reduction in transmission risk behaviors, and 60% better treatment compliance rates in some studies. So we know that integration of care is helpful in decreasing a lot of the systemic stigma and discrimination. So here are some recommendations. One of the things that I think is really important is implementation. We have tried many things and noted that there are some real implementation barriers to integrated care. So piloting in high need areas is essential. Making sure that there's confidentiality and privacy protections, that's very key. And using quality improvement modalities. All right, so the last thing I'll say before they drag me off the stage here is physical and digital communities impact adolescents. So one of the things that we're talking about is outside of the clinic. I can give you medications, I can give you therapy, but there are real benefits to the mental health care for community engagement. But community engagement is a double-edged sword, okay? So you might find community on Facebook, in a Facebook group. You also might get bullied 24/7, okay? You might get great support systems and opportunities in school, but you also might get peer pressure and other types of bullying and stigma, okay? So our communities are really important, but we have to engage youth very specific to their actual experiences specifically. And the last thing I'll say is families are a part of that community, and we can't leave them out. Everybody loves their families, no matter how hurtful they can be. So making parents better is always going to be worth the investment, okay? Making parents better is always going to be worth the investment. Everybody always wants to talk to the youth, okay? But if you talk to the parents for the same amount of time that you want to talk to the youth, you will make a lot more impact, okay? So we want adolescents to be engaging with their family in a developmentally appropriate way, and we want them to have the benefits of that social interaction. I'm going to stop there, and we will discuss later.